Let's review an example of the latter with clinical case number 3. A 53-year-old female patient is hospitalized in the intensive care unit because of a pneumonia and ARDS after undergoing a partial resection of her right lung for a neoplasia. Bilateral diffuse infiltrates are seen on the chest X-ray. A right chest tube is still in place. Because of a persistent fever, despite adequate antibiotic therapy, a CT scan of the chest was obtained to rule out a lung abscess. The CT scan revealed a significant left lower lobe pneumonia and diffuse infiltrates with a moderate-sized hydropneumothorax on the right despite the presence of a chest tube. This raises the possibility of a loculated effusion. This other CT scan axial cut obtained lower in the chest show once again the right moderate-sized posterior effusion and the left lower lobe consolidation with a small posterior effusion. The ultrasound clip obtained in the right lower chest is here shown. We can appreciate the presence of fibrin strands and loculations in the effusion, which are not really visualized on the CT scan image. We can also see a solid density attached to the diaphragmatic surface, which could represent an abscess or a metastasis. Because of the loculated nature of the effusion, use of real-time guidance for thoracentesis is indicated. The phased array probe provides an excellent view of the effusion and surrounding structures and is clearly the best probe to use to assess the effusion and needle entry site. Once a needle entry site is determined, the linear probe can be used to proceed with needle insertion. Because the linear probe does not allow imaging at high depth, only the superficial aspects of the effusion will be visualized as shown here. The distance between the skin and beginning of the effusion can then be measured so as to provide an indication of the depth at which the effusion will be reached. Let's now review the whole case. The probe is positioned in the posterior axillary line a few centimeters cranial to the site of the chest tube. The loculated pleural effusion is well visualized, and an optimal site for needle insertion can be determined. The area is then prepped and draped. The pleural space is then reassessed with the phased array probe, and the needle entry site and needle trajectory are confirmed. Imaging is then performed with the linear array probe in preparation for the real-time needle guidance. The distance between the skin and top of the pleural effusion is determined. Under ultrasound guidance, local analgesia is then performed using the transverse view. Note that at the end of the local anesthetic injection, the pleural space is penetrated with the small needle and pleural fluid is aspirated. This is followed right away by insertion of the large bore needle using real-time guidance in the transverse view. Once the needle has reached the pleural fluid, the ultrasound probe can be put aside and sampling or evacuation of the pleural fluid can be done using a large syringe. In this case, it was decided to convert what was supposed to be just a diagnostic tap into a pigtail catheter insertion, So a guide wire was inserted and then the rest of the pigtail catheter insertion was performed along what was previously demonstrated in the first two clinical cases. We can here see the pigtail catheter positioned in the right lower pleural space. Comparing the chest X-ray post-procedure to the one done before the procedure allows us to confirm a very good drainage of the pleural effusion. Remember that, although the use of ultrasound to help perform a safe thoracentesis significantly decreases the risk of complications such as pneumothorax and organ puncture, it does not decrease the risks associated with the interventional procedure itself, such as intercostal artery laceration, which will be unaffected by the use of sonography. Minimization of these risks depends on the procedural competence of the operator. Inclusion of sonography does not change the technique of pleural space access, it only defines the access location.